this webinar is focusing on the role of radiology in population health management. And there are many different definitions of population health management, as Ryan will also be attesting to and sharing. In general, this is one definition that I've come across, that from the Institute of Health Technology Transformation, that the goal of population health management is to keep a patient population as healthy as possible. And you want to minimize the need for expensive interventions, which includes imaging tests, as well as making sure that how are we delivering care to the whole population. And obviously now with using better tools such as automation, artificial intelligence, electronic records, then that, how do we make that feasible, scalable, and sustainable? Now, I've been inspired in my career by many people such as Rich Duzak, Frank Lexa, Jonathan Berlin, about population health management, and including Paul Chang, who's done a lot of work on this as to what is radiology's role in population health. And he defines it a few years ago in this way that we are acting as the gatekeeper and as the consultant on other use of healthcare services. We are starting to assume responsibility for disease surveillance, and then we're using CDS as well as the computerized systems to then make sure that there are appropriate tests being delivered, and as far as downstream care. And then obviously we are the leader in analytics and the computerized systems, so that we can actually spread those over the whole enterprise. And I want to acknowledge the ACR's help with developing this work with the Population Health Management Committee, and they helped me to put together this infographic slide, particularly Chris Hobson, who helps manage our committee. We can break population health management into three major buckets. Surveillance and prevention is the first phase, that someone's healthy, but they're just trying to make sure that they stay healthy, right? Then acute care, when you actually have symptoms, you're seeking care, right? Chest pain, abdominal pain, etc. And then the chronic care management. Once you have a diagnosis and you're just going to have to live with it for a long time, such as cancer, AAA, then how do we manage that? And the going into more detail on the surveillance and prevention, we know that we have a strong role to play in mammography. We have a growing role in low-dose chest CT, which is something that should be expanded a lot more. A lot of patients don't actually undergo low-dose chest CT who should. And then virtual colonoscopy, we have a role there. AAA screening for Medicare patients, older patients in particular. And then the growing AI tools, artificial intelligence, where it can detect disease states as they're developing, whether it's in conjunction with mammography or other imaging. In the acute care setting, a lot of focus obviously has gone into this. ACR has done great work on Imaging 3.0, which really, is not just acute care, but overlaps all of the population health management. But choosing wisely, recommendations are very important to follow, as well as best practice recommendations from ACR and other societies about what to do with incidentalomas. CDS, we know, has a strong role, and we have that role to work with other clinicians to guide them. And then inpatient care coordination. I think there's a lot of opportunity there. In my practice, I've taken this on as well. A lot of people are trying to think about how to make sure that we manage the inpatient care pathways, other clinical pathways. How do we work with subspecialists? Whether we are subspecialized ourselves or working with other subspecialists, how do we make sure that we use imaging appropriately in the right clinical conditions? And then chronic care management. So you have patients with AAA, with lung nodules. How do we make sure that they get followed up and that they don't fall through the cracks? We are actually going to be sharing that kind of work later on in this 6-part webinar series. Oncology intervention, obviously, we have a role to play in follow-up of cancer patients. And then the this is where it overlaps with surveillance and prevention as well, that if someone has fatty liver, they already have basically a chronic disease. Or if they have metabolic syndrome where they have, excess abdominal fat, then how can we as imaging consultants help follow these patients and guide them towards taking better care of their own health? And we have demonstrated that if we actually take care of these patients well, then we can actually improve the quality of their life. And the way that Medicare or other payers judge the effects of an intervention, we can actually improve the downstream qualities and, both save money, but actually improve the life expectancy of the patient population as well. And so of building on all of this, basically, this is the mission of our Population Health Management Committee under the Patient and Family Centered Care Commission. We are engaging radiologists and stakeholders, whether it's at CMS, the payers, the health systems, on the importance of the role of radiology in population health management. And I want to give a shout out to Paul Rosen, who I know is on this call, and we've done some great work with him and CMS on recognizing the role of radiology in PHM. And we're collaborating with other existing radiology PHM leaders to learn and disseminate the experiences of radiologists involved in this. You're going to hear from two of the leaders tonight. We also have a subset of a committee that's done great work under Dr. Deborah Dyer, the Lung Cancer Screening 2.0 Subcommittee. We're helping support their work. And so we have many ongoing projects. This webinar series is a 6-part webinar series. We had the health equity one last month. We have this one now, the kickoff of sort of the traditional population health management. We've had a great podcast series that Chris Hobson and this committee has been pioneering. And we have a PFCC toolkit, which we'll be adding a PHM section to, as well as working on the lung cancer screening centers of excellence. And obviously, the Commission on Economics and other PFCC committees are doing great work on this, and we are coordinating our efforts with them. So I'll stop there, and you can always feel free to contact me. We're on Twitter also, or LinkedIn, etc. I'll do an introduction to Dr. Ryan Lee at this point, who will be next to present his views and experience on population health management. Dr. Lee is an associate professor at the Sidney Kimmel College at Thomas Jefferson University. He's the vice chair of quality and safety in the Department of Radiology for the Einstein Healthcare Network. And he is also the section chief of neuro and magnetic and MRI medical director at Einstein. His wide interests include population health and the central role of radiology, as well as the clinical implementation of artificial intelligence, healthcare economics, and policy, and quality and safety. So he's been serving on many national committees. In addition, he's the AMA alternate RUC advisor for the ASNR, as well as a member of the AMA RUC multi-specialty points of comparison work group. So I welcome Dr. Ryan Lee.
Hey, thanks so much, Saeed. Can everybody see my screen? Just want to make sure.
Yes, we can. Thank you.
Great. Thank you. Thank you for that kind introduction. And yeah, thank you, Saeed, for your leadership on this committee and having me aboard. I'm really looking forward to participating in this role. I'd like to thank the ACR and the commission, the PFCC commission, for having me here speak tonight. So my goal tonight in my talk is really to give a background on what population health is, at least what I think it is, and perhaps more importantly, make the case for the central role of radiology in population health. Okay, so let's start. I want to give a backdrop to just give you an idea of how we got to where we are today, and in some ways, why population health is even here. So most of you have seen this graphic in some shape or form. We all know that we spend lots of money as the United States of America spends lots of money in healthcare, and it's no surprise seeing something like this. Not only do we spend more money, but we spend a lot more money than just about everybody else. And just so that it's not only the physicians, you can see here that our spending is really across the board higher than just about everybody else. And that includes hospitals, ambulatory care, administration, even pharmaceuticals. So there's plenty of cost to go around explaining why we spend so much money for healthcare. But for as much money as we spend in healthcare, it's not clear that all this money spent in healthcare has improved the quality of care in the United States. And at least by a metric of how long people live, you can see here that while most of the countries are sort of plotted along this area, the United States doesn't necessarily, despite spending all this money, have a better life expectancy than a lot of these other countries. So it's not clear that despite all this money that we're sinking into healthcare, that it's improving the quality of care. In 1997, the Balanced Budget Act was passed, and that actually resulted in a significant reduction of healthcare spending. Now, this was also where the infamous SGR came into existence. And really, it was essentially a complicated formula for determining the conversion factor, which is basically a multiplier that helps decide or explains how physicians get reimbursed. And it was a very complicated formula, but that infamous sustainable growth rate is embedded in this update adjustment factor and explains why over many years when this was actually supposed to be in use, that it would have resulted in significant healthcare physician cuts every year that it was implemented. And what had happened was over the years, for basically most of the 2000s, every year, Congress would have to step in and just have a 1 year, we're not using this way to calculate the conversion factor. And this went on for many years. In fact, this went on all the way until 2015, when the MACRA Act was passed, and then President Obama had signed it. And that actually put an end to the use of the sustainable growth rate and actually created the way we are now compensated as physicians in healthcare. And so what did MACRA do? Well, what MACRA did, it did two basic things for our purposes tonight. It repealed the use of the sustainable growth rate. And so that got a lot of applause from many groups across the board, but it also created what's now known as the Quality Payment Program. So what is that? Well, the Quality Payment Program essentially described the ways physicians would get reimbursed. And there was essentially two pathways. One was called MIPS, or the Merit-Based Incentive Payment System, and the other was called the Alternative Payment Model, or the APMs. And by default, all of us are paid through MIPS. And so what is MIPS? And I'll just briefly go through this. This is really its own talk, but essentially what MIPS describes is 4 different pillars in which we are essentially scored. And this composite score will then in turn decide how we will be reimbursed as physicians. And so the main 4 pillars are quality, cost, improvement activities, and promoting interoperability. And you can see the relative weight of each of these pillars in 2020. And you can see that as the years move forward, including 2021, cost increase and quality, the percentage of quality in terms of making up the MIPS categories and how we get reimbursed, and the factors that are involved actually will go down. And that actually will go up every single year. Now, how does this work exactly? Well, for each of those pillars, just in short, we are given a score, and each one of those scores will combine to give us one composite score. This composite score is then compared to something called the performance threshold. And depending on where we set our score relative to this performance threshold, we will either get a bonus or a penalty. Now, for 2020, the performance threshold is, you can see there, 45 points. So what that means is if your composite score is higher than that, well, you're actually eligible for a bonus. And if it's less than that, you are then going to be subject to a penalty in which you actually would owe some money. And if you're right at that performance threshold, well, you're at even Steven and you don't owe anything. Now, you can see here from 2020 to 21, that performance threshold jumps up quite dramatically. So what that means is the benchmark for what we have to do in each of those 4 pillars also goes up. Now, it's important to remember that this MIPS categorization is budget neutral. So what that means is for everybody that does well in this program, it's a bonus, somebody's going to have to pay for it. So that is actually it's a budget neutral. It's designed to be not cost Medicare anything, except you can see way above there at the 85 points. If you do really, really well, there's actually a set amount of money. It's about $500 million that's actually set aside that can be given to those organizations that do really well. Okay, so let's get into population health a little bit. And this is a very simplistic framework of how you can think of population health. We have our traditional way of how we were reimbursed, fee for service. Okay, we're all very familiar with that as radiologists. You do one procedure, you get paid. You do two procedures, you get paid for two procedures. And that's how it was in all of medicine. As we move more towards a quality world, you can see how these categories start to line up. The category 2 is kind of what most of us sit in. It's still fee for service, but there's some links to quality and value. And that's exactly where MIPS sits. Okay? As you move up the scale towards more of a quality-based environment, you now are in the alternative payment models. And for example, the prototypical APM would be just your basic MSSP or Medicare Shared Savings Program. And I'll go into that just a little bit more shortly. Finally, as you move fully into this value-based environment, you are not in a fee-for-service model for the most part, but in what you can consider a population-based payment. And that is the advanced alternative payment model. So we'll briefly describe what these things all are, but they actually all boil down to a few basic concepts. More specifically, we can think of when we go up through the scale from a regular fee-for-service to a pay-for-performance where you're not only reporting quality metrics, but you're also being counted on. That's kind of what MIPS is, the Merit-Based Incentive Program. As we move up the scale, we now move into something called shared savings. And those three things there, shared savings, bundle payments, and even to some degree, the full risk, all have elements of shared savings. And for example, I mentioned the MSSP, Medicare Shared Savings Program, is an example, the prototypical kind of ACO for a shared savings environment. A bundle payment, for example, would be a BPCI. And as you get more into the advanced payment models, you can have advanced BPCI and these next generation ACOs. And we'll briefly describe what these advanced payment models are. Before we get into that, it helps to have a concept of what an ACO or an accountable care organization is, because that's really the crux of population health. And a lot of times I think people use the words population health and accountable care organization sort of interchangeably, but they're, in my opinion, they're actually two distinct but very related things. An accountable care organization, at least from a CMS perspective, is actually a legal entity. But in order to run it properly, whether it's an ACO such as Medicare as defined or even private insurer type ACO, you need to have a good population health management program. So they're interrelated, but I think they're distinct concepts. And so what is an ACO? Well, it says it right here on the CMS webpage. The whole point is to you can voluntarily make these ACOs come together to give high quality care and at the same time spend healthcare dollars more wisely. That's really a euphemism for saying spend less money. So that's a basic concept of an ACO. And we can think of it more conceptually as bringing together all the different elements of healthcare, our doctors, our extended providers, our nurses, our hospitals, all of these things together in a coordinated fashion to take care of the patient, which should sit right in the middle of all of this. And that they're no longer silos, that you have a hospital, you have a radiologist, you have a primary care doctor, you have an ED doctor, but they all work in unison together to provide the best possible healthcare. And this really lies firmly square or maybe triangular with the IHI, the Institute of Healthcare Improvement's triple aim, which is to promote the health of everyone in a population. And that population is really, when we're talking about population health, the population that you are responsible for as an organization. Their experience of care, not only should we be taking good care of these patients, but that they should feel that it's good care and that we actually respect and actually promote that their experience is just as important as taking care of them, all at the same time reducing costs. So that's really the trifecta of the original IHI triple aim. And that really leads us into the prototypical type of an ACO, the Medicare Shared Savings Program, which is basically incorporates elements of everything I just talked about, that we're accountable for the care of a defined population. And then we coordinate all of these services for these patients, all at the same time making sure we maintain quality and decrease costs. So how does that work exactly? Well, the concept of shared savings is basically that we take care of a patient and we have to beat some kind of a benchmark. And that's really the concept of shared savings. And that when we beat this benchmark, that in the case of an MSSP, that CMS pretty much tells us, then we get to share in some of those savings. When we beat the benchmark, whatever amount of money that we have saved, we get to share with CMS. And that's the whole concept of shared savings. Now, it doesn't just end at, that's not where the story ends, because the whole concept of trying to decrease costs in an HMO setting has been tried before as early as the 90s. So the trick is not only to decrease costs, but to provide the healthcare with the best possible quality. So the hook there is not only do you have to show decreased costs, but in order to get that shared savings, you also have to meet a quality benchmark. Okay, so that's really the key. And you can see here, I know this is a busy slide, this is right from CMS, but this is the revised MSSP, the pathways to success, and it really describes how you move from a no risk, or I should say a single-sided risk, where if you share savings and you do show the quality, you get to partake in the savings. But if you actually had losses when you spent more money, you actually don't have to worry about it. That's the whole level A and B, to progressively moving up the scale with more and more risk. And basically, the whole concept of an advanced alternative payment model is that you're going to be taking a lot of more risk. And you can see in that enhanced track, which actually qualifies for that, you can see your shared loss, your maximum loss is up to 75%. So there's quite a bit of risk involved, but at the same time, there's quite a bit of upside if you're able to show that quality and decrease the cost at the same time. And with this revamped MSSP program, CMS did show that there was a pretty significant savings to Medicare. You can see there almost $1.2 billion of savings. So let's talk about an advanced alternative payment model. Most people in the Medicare Shared Savings Program are in at least they start off in a situation where it's one-sided risk. In other words, you get to partake if you do well, but you don't have to worry about the downside risk. But ultimately, what CMS wants everybody to do is to take two-sided risk. In other words, if you do well, you get the benefits. But if you spend too much money, well, you're going to have to pay up and owe them money. And the definition of an advanced alternative payment model is that you have to use an electronic health record, medical records. You have to base your payment on quality measures. And those quality measures are actually very simple to what's described in MIPS. And finally, perhaps the most important part is you have to take a lot of financial risk. So you are sharing that risk with CMS, and that's one of the critical components. And if you qualify and you are participating in one of these advanced APMs, you actually will get just an additional 5% bonus. This is CMS's carrot in trying to get people to do these things. You get just an automatic 5% bonus of what you're billing under Medicare Parts A and B. And in addition, you also get not to have to report MIPS, which is the default. If you're not in one of these advanced alternative payment models, you're a part of MIPS. So if you're in an advanced APM, this is just an example of some of the advanced APMs, and essentially they all describe some component or some form of a shared savings, and that showing decreased cost and good quality. Then you can have some of that shared savings. And conversely, if you don't, then you're going to owe money if you spend too much money. But again, the story never ends there. It's not just that you're participating as one of these advanced APM, but in order to qualify for that 5% bonus and to get out of reporting from MIPS, you have to show that 50%, either 50% of your payments of Part B are through this advanced APM, or more than 35% of your Medicare patients are through an advanced APM. So it's not just that you participate in an advanced APM, but you have to show significant participation in the APM as well. There are also other ways. If you don't meet that criteria, the third-party commercial versions of advanced alternative payment models can also qualify. And if the combination of those two is greater than those percentages, you also qualify for the 5% bonus as well. So finally, this brings me to population health. And Saeed gave some great definitions of population health, and I think this is where sometimes confusion can come in, and is that there are lots of different types of lots of different definitions, all of which are valid. In fact, this one I have up here is one of the first, may have been the first definition of population health: the distribution of health outcomes within a population, the determinants that influence distribution, and the policies and interventions that affect determinants. There's a mouthful there, and it really does describe what population health is. However, I really like this definition. And this definition is from one of my colleagues who's on the population health team at Einstein and also teaches the Jefferson Population Health Academy. I think this definition really, to me, encompasses what population health is, because it gives us a lot of clarity on what we need to be doing. It's the intentional and proactive organization of care that utilizes actionable data and information technology, collaborative teams, and clear goals to improve health outcomes for defined populations for whom the organization is accountable for cost and quality of care. I really like that definition that Shiva gives here, because it really tells us really everything we need to know about population health and what we need to do. What are some of the factors involved in population health? All of these things and doing well in all these things are critical in a good population health program. And I actually got this list from Dr. Mitch Kamansky, who leads the Population Health Academy at Jefferson University here in Philadelphia. And all of these things, in his opinion, are critical in the running of a good population health program. Now, this list is actually ordered. So in his opinion, the order of this is the most important part of running a good population health program. In other words, benchmarking is the most important part. And as you can see, radiology is way down low there. And I'd like to explore that a little bit more. Why is radiology perceived to be so low down? But not that these are not all important. So everything down to the bottom here, including quality and radiology, those are all important components in population health. Some of you might even be thinking, quality, why is that so low? Now, what he means by quality here is quality metrics, not the quality of healthcare. And so that just gives you an idea, because what's important in population health management is also managing costs. And unfortunately, finances do run a lot of what we do. And these are all important things to consider in addition, obviously, to taking care of our patients. I would argue, and this is the argument I'm gonna make here, is that radiology is important in population health because it is involved in almost every aspect of population health. And that's what I've outlined in green. I think radiology touches every aspect that you see here. And I'll go into this a little bit more. But let's just explore a little bit. Why is radiology perceived to be peripheral in population health? Well, in traditional radiology, we're in a fee-for-service environment, just like a lot of healthcare is traditionally fee-for-service. And it's based on volume. So in other words, we read a study, we get paid for that study, or we read 2 studies, we get paid for 2 studies. It's basically built on a volume-based sort of method. As we move into population health, though, we're moving away from volume, and we're more moving into a quality situation where we improve quality or decrease costs at the same time. And a lot of people say that's exactly what value is, maximizing quality at a decreased cost. Another way to look at this is that in traditional fee-for-service, things like radiology are revenue centers, because the more you do, the more money you make. However, as we move into a population health environment, that's not necessarily true, because radiology could be a cost center. Think of your inpatient that's billed as a DRG. You get one lump sum payment for a specific issue that patient has. In that situation, everything you do, including radiology, is actually cost you money. And so we have to alter our thinking from a fee-for-service kind of mode to more of what can we do in a population health in a value environment. And that is exactly aligned with Imaging 3.0 that the ACR has promoted. And that is looking at the patient, not just from dictate study, here's the report, but managing the entire patient and putting the patient at the center of what we do, everything from the beginning, from when the study is ordered, all the way to the end when it should be communicated. Now, I just want to give you examples as I finish up here of how I think radiology is really central in population health. Let's just take care coordination, primary care visits, annual wellness visits. I can give you so many examples of everything that we do in radiology, whether it's the women's imaging, managing patients from beginning to end, when they should be getting their screening mammograms, to coordinating with surgeons and pathologists. Colon cancer screening, same thing. Closing the loop, that is something that we take upon ourselves, because that's something, making sure that a report is actually given to the right person taking care of the patient is just as critical as dictating the report. These are all things that look at not just the report itself, but everything we do as radiologists. How about benchmarking, risk adjustment, and risk stratification? Well, as I mentioned, benchmarking is critical, because in an MSSP or any ACO, what the benchmark is could make or break how you do as an ACL. And how is that benchmarking done? Well, a lot of it's from risk adjustment, which is basically how risky are your patients? How complex are they? And that's important, not just for billing, which is what risk adjustment is, but for risk stratification. In other words, those patients that are very complex, are we getting them the service they need preemptively before something bad happens and they use lots of services down the line? Well, a lot of this comes down to coding, something called the HCC, hierarchical condition categories. And if we look at this coding, how can radiology help? Well, in a lot of ways, when we dictate a report, we give diagnoses that feed into these HCC codes. These HCC codes, in turn, will determine how complex or risky a patient is. What if we are more proactive, whether it's through AI software or otherwise, in helping our clinical colleagues say, hey, here are some diagnoses. Is this something you want to add to the problem list? Think of how much we can add to a network, making sure a patient is properly coded for risk stratification and risk adjustment purposes. Finally, inpatient management and quality. I can think of lots of things that we do as radiologists. For example, when we use dual energy CT in decreasing the number of head CTs, because previously we wouldn't be able to tell contrast staining versus if there's hemorrhage post TPA. If we can save images, save studies that way, that's how we can manage a decreased length of stay for these patients. How can we manage quality? How about managing when the right study is done at the appropriate time using CDS? Saeed had mentioned this earlier. CDS is a critical part of what we do, and that we have to make sure at the beginning that the right study is ordered. How frustrating is it when the patient gets the wrong study and we have to start all the way back at the beginning and get that patient back in the pipeline so they can get the right study? So lots of things that we can do as radiologists. So what's the take-home message here? Well, what I wanted to leave to you today is that while on the surface, radiologists may be perceived as being peripheral to population health, in reality, not only is radiology integral to population health, but it's in fact a leader in population health. When we embrace the tenets of Imaging 3.0 and make the patient central to everything we do, radiologists take the lead in the management of our patients in almost all parts of healthcare of population health. And I would challenge all of you to integrate some of these examples, and perhaps all these examples, and how we can lead the way in population health management, and also challenge you in finding new and innovative ways to improve our patients' population. Thank you.
Thanks, Ryan. That was an excellent overview of population health management with all the nuts and bolts and ABCs and alphabet soup that anyone can like. So I appreciate that. And now I'll introduce Dr. John Lonas, our colleague from Kansas, who's joining us tonight. And he trained in Iowa, then he was a senior fellow at Harbor UCLA in MRI and CT. He then joined Wichita Radiology Group, which is a leading group out there in Kansas, has been managing it for 25 years and now in his fourth year as chairman. He's worked a lot on the policy side. He's a member of the Medical Advisory Committee for Senator Marshall and Representative Estes from Kansas. He served as the CAC rep for Kansas for 25 years. He's the radiology representative to the Medical Advisory Committee for Blue Cross Blue Shield in Kansas for the last 27 years. He's also on the executive committee for Providers Network, which is a statewide PPO owned by the local medical society. And, you know, in all of his spare time, he also owns and operates a nice restaurant, Freddy's in Arizona. So without further ado, John, I'll hand it over to you. You can share your screen and your slides.
Thank you. I appreciate it. I'm going to approach this slightly differently. It's some of the same information. We've been doing some of this stuff over the last decade and continue to pursue these things. So this is more of a real life type arrangement. The things we've learned in 2020, life is all about risk. It's assessment, mitigation. How we handle it's the core of our personal, organizational, societal, professional organizations, operations. So we're going to take a look at some of the options available, how they might apply to radiology practices. The largest portion of radiologists continue to be employed in private practices as independent practices. This is the group where I...
John, I'll stop you there just for a second. I think you have to share your slides.
Oh, it's okay. Said
Let's
I
just
was.
make
Excuse
sure.
me.
That's
Let's try
okay.
that.
Great. Now we see
Thank
them.
you.
Thank you.
Okay.
Please go ahead. Thank you.
So from a perspective of a practicing radiologist, payment for services is a risk mitigation activity. Our job as physician leaders is to ensure timely and adequate payment for these services. Others are attempting to move all of medicine into a commodity status and not as a profession. Personally, I think it's for all physicians to work to oppose that shift. The concept of value has become a key word. If I can get there we go. In healthcare reimbursement, and the formula is pretty simple. Its value is quality over cost. Simple equation, massive implications. Implementation is everything, and it's difficult to quantify. As we've already heard, what is quality? Per episode of care, is it the decreased number of studies overall, the current studies performed earlier in the episode, right study, right time? Is it protocol optimization? Is it timeliness of studies? So from a patient's perspective, or for the office staff, primary care physician, is ease of scheduling, ease of access, departmental wait time when folks get there. Is it performing pre-authorization for folks? And then everybody's favorite metric, report turnaround time. Is it a robust QA program? Finally, bottom line, was the report correct? So your determinants of quality depend largely on who the audience is. Some of this is out of our hands. Correct studies to be performed in the protocol optimization requires better analysis upfront by physicians with that information relayed to our practices and not necessarily from triage nurses in EDs. As late Justice Potter Stewart said about a different topic, we know it when we see it. We recognize quality when we see it, but the definitions are insufficient. With the lack of a consistent defined numerator, the concept of value then devolves to cost, as it's the only variable we can quantify and adjust easily. As every patient and every payer tries to move into population-based criteria, all reimbursement becomes about decreasing risk to that payer. That's nothing new. For years, every payer has decided that they don't want to pay for studies and procedures. Common methodologies include the use of pre-authorization requirements or denials of payments or reduced payments. Risk mitigation for them is increasing the size of their patient populations and increasing premiums with decreased payments. An example as to how this plays out, I would point out to the response of MedPAC and their philosophy that I characterize as whack-a-mole. Whenever they see a rise in utilization, they assume it's because the procedure is too profitable. They cut reimbursement. Best example that I can give you took place with PET scanning. Prior to CMS authorization, utilization was basically non-existent. Upon authorization as a covered service, PET scanning became a valuable addition to patient assessment and treatment planning. The next year, reimbursement was cut as utilization went up geometrically. CMS implemented guidelines to cut utilization, and other insurers have behaved in a similar manner. Buried within the discussion, but driving most of the decisions for radiology practices, is the concept of personal risk. Radiology practices are generally considered to meet the criteria of a mid-sized company, that is, revenues between $10 million and $1 billion, as defined by the Ohio State University's National Center for the Middle Market. We don't often think that way. Rather than deal with these potential risks, many groups throughout medicine made a simple choice. They've sold their organizations, maybe to a hospital-based organization or to a single specialty organization. Think cardiology in particular. There's already been a discussion of macro and MIPS as a concept to increase quality and value. I think most everyone would agree that these hoops through which we jump have little to no effect on the quality of outcomes. Because of radiology's adoption of digitalization of our practices, we've blown through many of the criteria already initially specified. The advent of Obamacare resulted in a variety of additional metrics to meet and hoops through which to jump. After we passed it and found out what was in it, we discovered the concept of the accountable care organizations, ACOs. This is a slide of just some of the stuff that law offered for the Secretary of Health and Human Services to participate in. Medicare initially established two variations designed to promote cost sharing, better integration of the various entities involved in episodes of care, allowing for bundled payments to the entity to be distributed amongst the various involved practices. One of the proposals was for a risk-sharing approach. The other was a shared savings program, as we've heard. Throughout the country, 17 organizations initially signed up for what was called the Pioneer program that included downside risk, while more than 300 signed up for the shared savings program. Radiologists, as can all specialists, may participate in more than one Medicare ACO. Primary care physicians may not. My first question to ask is, who owns the ACO? If the hospital owns it, the ACO is really working at cross purposes. As we saw in Dr. Lee's slides, the single biggest cost is hospital-based care. Even if vertically integrated with their own PCPs and specialists, the hospital will be first to the table on the monetary splits. The better operational designs work to diminish numbers of inpatients and the length of their stays if admitted. The coordination of care through a shared EMR may be helpful. If the hospital owns the ACO, they'll most likely have their own primary care physicians and hospitalists. The bundling of payments may well shut radiology out of the ability to engage in discussions, such as distribution of funds, relegating radiology to a hired service. In such a scenario, it may be possible, unless otherwise specified in your contracts, they could change to a different provider organization or group. In this scenario, radiology becomes strictly a commodity. Physician-owned ACOs offer better chance for ensuring physicians get the bulk of reimbursements for better care coordination, appropriateness of care. Primary care physicians have the burdens for patient management and record keeping. The Medicare shared savings portions of the ACO's patient allocation was based upon which provider was seeing patients most frequently. Based on historical data, which was basically a Medicare black box, a defined amount of money would be allocated for the care of those patients. If the utilization was less, potential for savings and sharing those savings is greater. As I mentioned before, in any scenario, the largest cost in the healthcare system is hospital related, specifically ER visits and inpatient stays. Primary care physicians are largely responsible for ER visits. That's mostly a matter of access to those primary care physicians. And inpatient stays are governed by specialists, more recently hospitalists. We did a shared saving ACO. I spent a year lobbying to be on the executive committee and have our group as a founding partner in the organization. If your group is not on that same level as other medical practices, then radiology is only a cost center and is such a commodity. Once on the executive committee, I made sure that every subcommittee had at least one radiologist serving on those committees. We ensured that every patient care protocol was reviewed and conformed to the best practice protocols, whether it be ACR appropriateness criteria or Intermountain protocols. Those were the two that I used most frequently to try to ensure that evidence-based criteria were in place. We were small by ACO standards, a reflection of the Wichita market and the primary care physicians involved. We had about 15,000 covered members, but our allocated amount was still surprisingly high to me at $150 million. We made a couple of mistakes, largest being integration of medical oncology into the organization for political purposes. 8 of the 10 highest cost patients were oncology related. The other 2 were kidney stone patients with inopportune ER visits. The establishment of the ACO did allow us to turn hospitals into contracted service providers, and that was big. In a Medicare Shared Savings Program, CMS, as you saw on that busy slide, CMS gets their share first. Again, whoever owns the organization gets paid first. Then distribution is made to the ACO. The documents establishing the ACO in our case also had the distribution framework for any of the savings as a separate attached document. And that's been, you can find it in one of the Imaging 3.0 pieces that we did about the ACO back 5-6 years ago. Next piece of the pie was established for patients allocated based on the number of allocated patients. Remainder was then shared equally between primary care and specialty groups. And payment for individual services was standard Medicare rates for those CPT codes. Had we excluded oncology, we would have saved about 15% that first year. As it was, we still saved in excess of $5 million. One of the problems we encountered going forward is the same money cannot be saved year over year. Whatever was saved then had 70% of that amount deducted from the following year's total projected spend. Later in the second year while we were doing this, the rules came out for the years 4 through 6. By years 5 and 6, it would have been a risk losing event for which we would increasingly be responsible for payments back to CMS. Loss of flexibility in the marketplace for the primary care docs was significant to their practices, as the 2 hospital systems in our region were seeking to develop their own ACO type entities, combined with the inability to project savings for years 3 to 6 with an aging population and likely increased utilization by those patients and decreasing funding. We also had problems with CMS not following our own rules to sharing arrangements, and we didn't know if that would improve. Others around the country did better. Many are still in existence. Number of ACOs reached a peak in 2018 at 561 organizations. At the beginning of the year, this year, the number was 517. Locally, one hospital-based ACO didn't survive, as the hospital took a disproportionate share of the income and there were no savings. The business associated with this plan lost money. I mentioned the concept of bundled payments. This poses a potential problem for groups in that the monies will go to the primary physicians involved or the facility and then distributed from there. This could lead to hospitals and facilities picking winners and losers. Physicians referring patients win, think cardiology, orthopedics. Rather than fight the fight that could create, we place language in our hospital and facility contracts that specifies how the group is to be paid in those situations in a formula that crosses all payers. It specifies that the PC portion of radiology services will be paid at the outpatient rate for that payer for those CPT codes, and there will be no facility or other charges for distribution of those payments. With those criteria, we can appropriately track what we should have been getting. Excuse me. We also have language that precludes facilities, and this one's important, in engaging in unfair and disproportionate reductions in managed care contracts. The latter is to protect hospital-based physician practices, like ours, from others negotiating contracts that negatively impact radiology practices as compared to the hospital and other practices in order to arrange savings back to the payer or employer. Operationally, beginning in 2000, we sought to aggressively grow our practice outside the usual hospital constraints. Historically, 2/3 and now 3/4 of the total payment for a procedure is for the technical aspects of that procedure. My phrase for this is own your imaging. As an independent practice, we had that flexibility to do so. We chose carefully. We didn't want to be seen as a competitor to our main hospital partner. They were 95% of our business at the time. We made sure that we didn't hire their staff, and areas they didn't want to enter, we did. For example, at that time, hospital reimbursement from Medicare for HOPS for any related breast procedure, whether it's screening, diagnostic, ultrasound, or breast surgeries, the reimbursement from Medicare didn't cover their costs. We have a residency. It requires access to meaningful numbers of patients. In a series of meetings with local pathologists and surgeons, we established what has become one of the larger breast imaging centers in the central US. It offers us the opportunity for quality control, the ability to change quickly for practice parameters. And right now, amongst all of the various entities in our marketplace, we're a tier 1 facility, even with those that would be considered normally our competitors. Again, that's because of value to the patient, value to the outcomes. Most recently, we did a clinical IR practice because once again, the hospital wasn't capable of letting us meet the residency requirements for the new IR tracks. So where are we now? This year, the hospital with no reductions and the usual interval growth in the numbers and the complexity of their studies are only 23% of our business. The opportunity for independent practice going forward will also depend on the ability to develop the data necessary. And in order to establish those criteria for contract negotiations, insurers, other health organizations will have that data, only some of which they're willing to share. They also have to be willing to engage in those conversations. Back in the 90s, changing laws opened up new avenues for patient insurance. ERISA-based contracts were used to form health maintenance organizations. These older organizations can serve as a template for those groups that choose to become further integrated into the financial side of medical reimbursement. Short form discussion for this is the development of data for a defined population on a per 1,000 member basis. This starts with demographic age analysis of the group to be covered, followed by test utilization for evaluating their utilization in prior years. You should attempt to match your current reimbursement for those patients so you aren't losing money as you begin the effort. 2.5 years ago, a group of 5 of us began to work on insurance plan design and implementation for physician-owned PPO in my home market. Of that initial 5, 2 were primary care docs, family practitioners, 2 were administrative staff, and I was the token specialist. By plan design, we were able to project significant savings while reducing administrative burdens upon the primary care practices. Our test groups totaled 1,500 covered lives. The total savings were 30% as compared to our standard product. After a year, the base costs for their insurance to the 2 groups that were part of this were decreased by 11%. We anticipate a similar rate reduction in their next renewal. As part of this structure, directing patients to appropriate facilities is a key. If we were able to put together outpatient carve-out for imaging, we would determine the appropriate equipment, more efficient CTs, say 64 or higher slices, higher strength magnets with fewer, more appropriate callbacks. Could this result in lower utilization rates? Absolutely. Actual data from that first year is included here. The PPO is providers care. That had a group of about 30,000 patients for which we had a 4-year look back. Nexus is our new version. And as you can see, we had a 66% drop in CT utilization, nearly a 16% drop in ultrasound. X-ray stayed about the same. So broken fingers, toes, arms, whatever, chest X-rays are going to be utilized in about the same rate. MRI, however, had a significant reduction. From the patient and the employers and the insurer's perspective, the concern is that the outcomes are equivalent or better for the patients in that first column. Subsequent questions will center on the level of illness over a population and who is the lower cost provider with the best outcomes. As a quick summary, the areas where practices can participate is development of appropriate imaging protocols, any type of organization, and developing a specialty carve-out where as a practice you become a mini insurer, either with the insurance company itself or where the primary cares take risk as a managed care organization. The basic questions for any group are as follows. What conditions, medical conditions, provider groups are we involved with? For us, it began with women's imaging. What is the role of the radiologist in episodes of care? Where in your group is the hierarchy or the operational setup? Do you have a say? And by group, I mean the practice as a whole, not the radiology group specifically. What are the outcomes for these conditions? Do you meet or exceed the pickup rates as in breast cancer rates or callback numbers? How many studies require additional imaging? The concept of radiology self-referral is first and foremost amongst the minds of many of these payers. Which of these can you influence and affect? Outcomes. Do you need additional training for your physicians? or your technology staff. Protocol development. It may take greater conversations with your primary care physician so you're doing the right thing. Can you perform your task more efficiently? Is it image distribution, subspecialty reads, for example? What takes somebody 20 minutes for an ankle MRI, an MSK guy may be done in 5. And the last couple of questions here. How can you focus your practice to maximize your value? And to whom are you seeking to show the value? What definitions of value are you emphasizing? How and where do you embed yourself in your group in the episode of care? That's sort of like the first area talked about above. You want to be at the table and not just a hired hand. And how can you affiliate with other organizations to expand your reach and volume? I appreciate everybody's time and attention. Hopefully these webinars will help whet your appetite to explore more fully your group and personal options moving forward into the future. Saeed?
Thanks, John. That's excellent. Really appreciate all your experience and work, especially on the private practice side. And I know we're running a little bit long, but we can take any questions that people have. One question that came in, how do you feel like population health relates to health equity? So I'll take that one. I think that population health management, obviously it involves making sure that all of your population is receiving the appropriate care. And we know that we have underserved populations, whether it's in the inner cities or the rural areas. Many people in America being left behind, even though we have the best economy in the world. So there are health disparities in different, whether it's ethnicities or, as I said, underserved areas, different types of social classes and socioeconomic status. So we have to address all of those and make sure that if we are leading population health management for our health system, then we are taking into account how to make sure that we include as many people as possible. One question for John, you mentioned, I was intrigued by, you showed a significant, very high drop in CT utilization. What was your experience in increasing, perhaps any strategies that you had in increasing the appropriate utilization?
Yeah, because it's a single year, I don't think that's probably a real number, first of all. I'll be getting updated.
Or, just making sure of incidentaloма follow-up.
Sure, got that. And as you showed in your prior practice, making sure that folks get the follow-up care they need appropriately is a huge marker for radiology.
Yes, excellent. Ryan, questions for you. I think a question came in on how do we make sure that we are working through the advanced APMs. I think there's a lot of education needed there. If you are participating in one of the advanced APMs, do they automatically get the 5% bonus? And if they're in an ACO and an MSSP, is that an advanced APM? So maybe you can expand on that.
Yeah, unfortunately, it's not as simple as simply just being an advanced APM. You also have to show that a lot of your patients or a lot of your revenue is derived from that advanced alternative payment model. And so you have to show at least 50% revenue of your Medicare patients to get that 5% bonus, or if you can show that 35% of your Medicare patients are actually enrolled in that ACO or attributed to you, then you can get that 5% bonus. So it's very difficult for radiologists solo, in fact, probably impossible to be an advanced alternative payment model solely. And and it's much easier just by design. These things were originally designed around the primary care physician to be part of a multi-specialty network, to become to be a part of one of these advanced APMs. So it's critical as radiologists that we work with our other colleagues in different specialties and to make that advanced alternative payment model work.
That's great. And Ryan, a question for you, since you're a specialist in neuro. What do you think about the role of artificial intelligence in population health management, and comparing it to MRI for neuro, and what that did to transform the specialty? How do you view that fitting into your framework?
Oh yeah, I think artificial intelligence, or maybe the better way to put it is augmented intelligence, the combination of using the AI software and the radiology together, there's no question it's going to be the future of radiology. And as far as how it integrates with population health, it's critical. As John had mentioned in his presentation, it's the use of data that really drives a good population health program, because you really need to understand what's happening with your patients. But from a more specific approach, you mentioned how we can use it. For example, we have a lot of AI algorithms where I work. One of them is intracranial hemorrhage. And is it right now, it probably doesn't decrease the amount of time that it takes for us to interpret, but it's a work in progress. And I think it's ultimately showing us that how we can use this in the future to help us. I gave the example of dual energy CT and how we have decreased the number of studies for these inpatients after thrombectomy, because now we can say, this is contrasting. It's not intracranial hemorrhage when we get the follow-up head CT after thrombectomy. And when you do enough patients and you decrease the length of those patients over time, that is an example of population health. That's how we're adding value to the patient, and not just indiscriminately scanning back in the day when we would have to, when we couldn't figure those things out. So absolutely, it's a big part of the future.
And John, one question for you, since you're fighting there in the grassroots on taking on risk, and we're facing some year-end reimbursement cuts for radiology and other specialties. So obviously I think that's where we have to move beyond fee-for-service. And how do you think you want to advise people about how population health management fits into the new paradigm that we're facing?
Well, first of all, I want everybody to write their congressmen and senators and let them know that we support a moratorium. If you haven't done that, please do so. There's good information on the ACR website as to how to do that. Ultimately, that's going to come through. CMS will follow, and right now, I think it was Azar last week who said, basically, stop your whining. He was nicer in how he said it, but that was sort of the upshot. In terms of what we're doing, our next product for Nexus is called Nexus Connect. That is a slightly decreased provider panel. It'll be 90% of our docs, basically, they'll qualify as being on that panel. Within that, I'm working to do a radiology carve out for all outpatient imaging. And then, as I said in my piece, then we get to set the parameters as to how things are done. Instead of a 0.7 magnet or a 0.5, you're at a 1.5 or a 3, depending on what it is you need to do, that your breast cancer pickup rate is appropriate. Our system, for example, is better than national numbers, national averages. That's where you want to be, and you want to move the practices to that level. By controlling it, becoming a mini insurance company yourself, you have that opportunity to define those things, and that's where we're going to go.
Yes, I fully agree. Ryan, any comments on that?
Yeah, no, I agree with John. I don't know.
Yes, and you know, I would also second what he said about advocacy. You know, I'm on the board of RATPAC, so always trying to drive support for RATPAC. Please, please support the advocacy efforts, as John said, because we need everyone involved in making sure that radiology voice is heard in and supported in Washington, D.C. and across the country. Well, I think we have, yes, one question came in. How will PHM strategies adjust in the face of increasing or inevitable corporatization? PHM is more or less viable given that path for radiology. I will answer that I think the whether it's consolidation, corporatization, any word that you want to call it, you know, healthcare is consolidating, and it is very important to do population health management at scale. You see in the large cities, major markets, you know, major health systems, whether it's UPenn, Thomas Jefferson, Mount Sinai in New York, Johns Hopkins in Baltimore, they're all looking to build up scale that way. So radiology groups, I think, as John Lonas said, we have to figure out how to expand our sphere of influence, whether it's partnering with each other, partnering with the health systems. And actually, population health management becomes more important because then the larger scale that you have, you can take on risk. You can do the kinds of things that John has done. You can do the kinds of things where Ryan is taking a leadership role in his health system, not just for radiology, but guiding the efforts at the health system level. And so for us to be taken seriously by insurers and by the health system, by the other physician colleagues that we have to be able to drive these outcomes. We have to have scale. We have to then manage the data analytics. And so I think PHM actually becomes more and more important as the healthcare space continues to consolidate.
Yeah, I agree with you, Saeed. The setting, whether it's corporatization, it's integrated network, it's a community hospital, it's all the same in terms that we're still going to be reimbursed by the same third-party payers or CMS, and it's incumbent on us to embrace these tenets of population health. And I agree, the bigger the scale, the more important it becomes.
And just one final thing on my view of it, we're at the center of the medical enterprise. There's no place I'd rather be moving forward, and radiology offers us that opportunity. It just has to be perceived as such.
Yes, exactly. Couldn't agree more. Well, I think I don't see any more questions. I know we're over time. I appreciate everyone's patience. I want to thank Dr. Ryan Lee and Dr. John Lonas for joining us